the speaker is Dr. Fuchsia Howard, and just a brief introduction for Fuchsia is she's presenting today on an interesting topic, ICU survivorship, and how chronic critical illness is related to ICU survivorship, and of course we know cancer survivorship and chronic critical illness. So this is an interesting topic going forward with new concepts. So I'm really excited to hear about this. Dr. Howard is an assistant professor in the School of Nursing in the Faculty of Applied Sciences at the University of British Columbia. And she has contributed extensively to survivorship research when in earlier work, her topic has been the adolescent and young adult survivors of childhood cancers. And she has published extensively, she has presented, and she has actually done a lot of advocating for some of the populations in that group. So I think I will stop here and hand it off to Fuchsia, and we'll go for the 45 minutes presentation and then have time for Q&A. So get your questions lined up as we hear Fuchsia.
Great, thank you, Armene, and good morning, everyone, and afternoon for those of you who are in Eastern Canada. As Armene said, I'm going to be talking to you about something a bit different than cancer, critical illness or ICU survivorship, but I'm going to draw some parallels to cancer survivorship, and I'm sure that you will see some of the similarities in terms of cancer and critical illness. And before I start, I want to acknowledge that in this research, my clinical colleague, Dr. Greg Haljan, has very much been an equal partner in all of this research, and so want to acknowledge him before I get started. And he's the department head of critical care at Surrey Memorial Hospital in Fraser Health, and a clinical associate professor at UBC. And before I start, I also want to acknowledge that I live and work on the Vancouver campus at the University of British Columbia. And UBC is located on the traditional, ancestral, and unceded territory of the Musqueam First Nation. And I know many of you are joining from different territories today, and I just welcome you to take a moment to consider the territory that you are on. So let's make sure I can, oh, there it works. So today I'm going to introduce the concept of critical illness survivorship and talk a little bit about what's called post-intensive care syndrome. I'm going to consider some of the lessons learned from cancer survivorship and their relevance to critical illness survivorship. And I'm going to spend some time describing some of the research that I've done specifically in the area of survivors of chronic critical illness, which is a subgroup of ICU survivors. And I'll just briefly introduce a study that we're just about to launch that's focused on drivers of unplanned readmission, hospital readmission for ICU survivors. So who ends up in the ICU? Well, it's quite a heterogeneous population, really, but any individual who's had an accident or trauma can end up in the ICU. Individuals who have an assortment of different illnesses, but primarily sepsis, which is the body's response to an infection. People can end up in the ICU after surgery if they've had a tough surgery or aren't able to be extubated, so have the ventilator taken out. And some people who have cancer also end up in the ICU, as many of you know. The focus previously, well, still actually, the focus of ICU care is very much on saving a patient's life. So all the stops are taken out, every technology is applied, and the focus is very much on saving life. And to do that, it requires close monitoring and life-sustaining treatment. The primary one being mechanical ventilation, which I'm sure all of you have heard a tremendous amount about, especially in the era of COVID now. But also medications and various procedures are used for treating underlying disease, but also to sustain life. And because of the invasiveness of the therapies and the monitoring, many patients are unconscious, they're sedated, and they're largely immobile for much of the time that they're in the ICU. We also are coming to understand that ICU survivorship is much bigger than previously anticipated. I was looking at some data recently, and we found that, in fact, more adults are admitted to an ICU every year. So in 2013-14, it was just over 200,000. Then are actually diagnosed with a new cancer. And so the latest numbers that I could find were from 2016-17, and that was 200,000 newly diagnosed with cancer. So in terms of survivorship, we're talking similar numbers of ICU survivors and cancer survivors. And the good news is that because of advances in science and medicine, now approximately 80% of all ICU patients actually go on to survive. And that number is 28-day mortality. So beyond 28 days, it's a bit of a different story, but within the ICU, 28-day mortality is around 80%. And because most patients survive, mortality is no longer the primary outcome that defines quality of care in the ICU. So much like cancer, there can be a tremendous cost of cure. And so while 80% survive the first 28 days, when we look at 1 year mortality, it's a bit different. So studies range quite a bit, but mortality at 1 year for those who survive range anywhere from around 25% to 63%, give or take. The other really important sort of data that's come out is that though 80% of people will actually make it home after being in the ICU, we're finding that in published data, 38 to 41% of people actually will be readmitted to a hospital within the first year. And in fact, we did some analysis of one of the local health authorities here, Fraser Health Authority, which in BC is the largest health authority in the province. And we found that at 1 month, 16% of ICU survivors made it back to the hospital. At 6 months, that rose to 40%. And within a year, that was 50%. So we're finding half of people who leave the ICU are actually coming back to the hospital. What else is really important is that when you look at family satisfaction of patients who survive critical illness, it's actually significantly lower than the family satisfaction of patients who die. So families of patients who die are more satisfied than those whose family member actually survives. The other part, and I'm going to go on to focus on this next, is that about 1/4 to half of all critical illness survivors suffer new or ongoing health challenges. And these together are called post-intensive care syndrome. And so post-intensive care syndrome, or PICS for short, was coined about 10 years ago. And it's a constellation of physical impairment, cognitive impairment, and mental health impairment for the survivor. But there's also what's called PICS family. So recognizing that family also face challenges. So when we talk about physical impairment, studies have really focused on what's called ICU acquired weakness. And this leads to shortness of breath, impaired lung functioning, neuromuscular weakness, sleep disturbances, difficulty sleeping. So very impaired functioning that is sustained and does not just get better on its own. And so this ICU acquired weakness is experienced by 1/3 of all patients who are on a ventilator and about 50% of all patients who have a disease called sepsis. Cognitive impairment is also very debilitating and it can include impairment in executive function, memory, attention, mental processing speed. And cognitive impairment has been reported. I mean, there's a huge range in the literature, really, but it's been reported in up to 60% of all ICU survivors. So a significant number of people. And then when people are in the ICU, one of the things that happens is they often experience things like delusions, hallucinations, and nightmares. And you can imagine that these hallucinations and nightmares, they stick with people. And those, along with the physical impairment and the cognitive impairment, can really have lasting effects on mental health. And so though the ranges are quite large, anxiety's been reported in 30 to 60%, depression in 8 to 57%, and a significant number suffer symptoms of post-traumatic stress disorder. So you can imagine all of these physical, cognitive, and mental health impairments are also contributing to difficulties returning to work, functioning in relationships, having meaningful relationships with others. And so that's sort of a quick and dirty of post-intensive care syndrome, but I'm just going to go over some firsthand accounts of what it's like to be in the ICU. And this is the firsthand account of a woman, Nancy Andrews, and some of her artwork. And so she says, these are her words: "For 3 weeks, I was held in a room. I was tied to the bed if I tried to get away. I couldn't talk. I couldn't eat. I was not allowed to sleep. Groups of people would enter the room and look at me and talk about me, and I was sometimes undressed in front of a small audience. I was shot full of drugs. I was too weak to move. Sometimes they would move me into another room so they couldn't secretly try to kill me or wait until the middle of the night to kill me. I told my partner about the enemy in hushed tones so that they would not hear and redouble their efforts to kill me. Where was I? They asked me every day, and I never knew the answer. What happened to me in the hospital? Yes, my life was saved, and I am grateful for that. But life after the ICU was extraordinarily difficult, not only physically, but also mentally." And so I'm just going to read to you one more patient account, and this is from an anonymous survivor from the ICU Delirium website, and people can write in and provide some of their own testimonials. And so this testimonial was from a woman who had been diagnosed with acute respiratory distress syndrome and placed on a ventilator. And so she's writing about long after she had been discharged from ICU. And she says, "It's been 2 years and I'm still trying to sort out what was real and what wasn't. I still think about it several times a week and continue to ask questions of my family. I have a compelling need to know what happened to me. I was on a ventilator and heavily sedated for 9 days. I experienced a prolonged nightmare. The theme: I was in an experimental hospital to learn what it's like to be completely dependent on someone else. After I was extubated and sedation was discontinued, I continued to have paranoid delusions about the nurses wanting to harm me. I was hallucinating at times, especially at night when I was alone. I saw outlines of skeletons on the wall, heard strange sounds, etc. At discharge, the neuropsychological evaluation revealed significant deficits. I was never told by anyone what to expect. After 5 months, I returned to work, but was fired 10 weeks later. I was devastated because I am a successful professional and had never lost a job. At the time, it didn't surprise me because I was struggling terribly. I couldn't organize my work, committed many errors in documentation, frequently lost things, forgot meetings. I tried to hide it and compensate, but to no avail. So you can see in these patient accounts that it's really quite an ordeal to go through ICU and then to survive. And the problem being that most people, after they've left the hospital, they often aren't even aware of the risks for post-intensive care syndrome or the ongoing problems that they're going to face. And there really is limited, in Canada anyway, limited post-hospital critical illness survivorship care. And so what that means is that patients are often lost in transition from the hospital to community care, much like what happens in cancer. There's also rarely programs or professionals that even know about PICS or critical illness survivorship. And survivors often end up suffering alone because they don't have opportunities to connect with others who may have gone through similar things. And many are actually also embarrassed and unsure, especially with those who are suffering from mental health problems. And so there's limited services in the form of personalized supports at the time of hospital discharge. There's limited follow-up medical or even psychosocial care, and there's really limited rehab or services. So it's quite surprising, when you think about people who survive, for example, a heart attack, cardiac rehab's pretty common and available and accessible in most places across Canada, but it's not the same if someone just ends up in the ICU, for example, from sepsis. So you're probably not surprised then to hear that people are starting to recognize the need for change. And there's some individuals who've been lobbying quite heavily and trying to put the word out here. And so this physician, Daniela Lamas, she's a physician in Boston, and she often writes for the New York Times. And one of her opinion pieces, this is back in 2017, says, "My ICU patient survived. Is that enough?" And I think we all know the answer is no. And another individual, Jack Awashina, who's in Michigan, wrote a really interesting editorial. And this is back in 2010. And in this editorial, he really says that survivorship will be the defining challenge of critical care in the 21st century. And you can imagine this is a huge shift from thinking about, saving people's lives as not being enough, and thinking about ICU as having to also think about survivorship. And so he also went on to compare cancer and critical illness survivorship. And so, like cancer survivors, and this is not new to any of you, critical illness survivors emerge from highly technical treatment. They face profound existential uncertainties and alienated relationships from their own bodies, but also from others in their lives. Many feel disconnected from primary care providers and their previous support networks. The survivorship in terms of care is complex and poorly planned, if at all. And the other part is that there is also a substantial burden on family caregivers who end up providing much of the care that people need when they get home. They also provide emotional support, and they end up coordinating much of the medical care that they need ongoing. And so some of the lessons learned from cancer that could be applied to critical illness survivorship is that survivorship really needs to be endorsed and supported institutionally. And we've seen that in cancer care, especially out of the United States with the Institute of Medicine report, the US National Cancer Institute, and the CDC, for example. The same has not yet happened for ICU survivorship, but I know many are working on that. Survivorship really does require, as we know, innovative multidisciplinary teams and new models of care that bridge those acute care and those community services. Also, models of care and rehab and interventions that work in cancer care might actually have some relevance for critical illness survivorship. So the idea that, if we're thinking ICU survivors, we probably shouldn't be starting from scratch and reinventing the wheel, that there are other places we can look to where great work has been done. And also this idea that recognizing that survivorship doesn't start at the end of treatment, that it actually starts at the beginning of treatment, and that threads of survivorship need to be drawn throughout the illness trajectory. And then the other thing that's, I think, really important to learn from cancer that I think should inform critical illness survivorship is that survivors themselves are actually tremendously powerful partners for change and for advocacy. And so harnessing and supporting survivors to advocate, I think, is a really important step forward. Okay, so I'm just going to take a step back and talk a little bit about my journey. Armine touched on that, but I really came from a cancer world. My program of research has focused on cancer prevention in my doctoral work, and then cancer survivorship. And as Armine mentioned, I was working with her in my postdoc. And with Dr. Karen Goddard at BC Cancer Agency. And I was very much focused on the health service needs of childhood cancer survivors. And during that time, I ended up talking with my clinical colleague and I was telling him about my research, and he said, he's an intensivist. He said, I think my patients in the ICU face similar challenges, and there aren't health services for these individuals. And what can we do about this? And so really a collaboration was born at that point. And not to say that I don't continue to do cancer survivorship research and have my foot in that door, but I have broadened my research to include critical illness survivorship. And I've been really lucky to be supported to do so through the Michael Smith Foundation for Health Research. So just a shout out to my funder. And recently was able to secure a new investigator scholar award to look specifically at critical illness survivorship. And so I'm trying to use lessons learned in cancer survivorship and apply it in what ways we can. And my focus is on trying to generate patient and family perspective evidence as the foundation for health and disability care. And trying to think about how we can design health services and interventions that actually meet patients' priorities and their needs. And so that is sort of how I became interested in critical illness survivorship. And so I'm going to briefly go through, there's 3 studies I've been involved in the area of ICU survivorship. The first was the first study that I embarked on with my clinical colleague. And that was very much trying to figure out what the evidence is to help establish an ICU follow-up clinic. And he has started to see these patients and get a clinic off the ground. And so I was doing a realist synthesis that looks at what are the interventions that might be helpful. I have to say it's a bigger body of research than I had anticipated, and there's lots of contradictory findings, so it's taken longer than I thought, and not as exciting to share with you today. So I'm not going to go over study 1, but I just wanted to let you know that's sort of where I started. And then the second study was a subgroup of ICU survivors, and those are with chronic critical illness, and that's what I'm going to talk about mostly today because it's pretty much finished. And then the third study I'll just touch on because we're about to launch this study in this spring. Okay, so the second study was really about healthcare expectations and sources of distress of people with chronic critical illness, their family members, and healthcare providers. And just to acknowledge the funding from Michael Smith for this particular grant, and also that this was done in collaboration between UBC and the Fraser Health Authority. But before I go into the details of this study, I just want to tell you a little bit about who people with chronic critical illness are. So I initially talked about individuals, those 80% of individuals who are survivors of ICU. But what we also know is that there's a subgroup of about 5 to 10% of those who become what's called chronically critically ill. And so these are individuals who they're no longer dying, actively dying, but they're also not fully recovering, and they're not fully recovered. So they progress to persistent dependence on life-sustaining treatment. And the hallmark of chronic critical illness is a dependence on prolonged mechanical ventilation. So these are individuals who can't necessarily get off the ventilator. But they also have a whole host of other physical and psychological issues, and they suffer repeat episodes of infection and organ dysfunction. So they're not individuals, for example, like someone who might have a spinal cord injury who physically the rest of their body is okay, and they are dependent on a ventilator. These are individuals who are dependent on a ventilator, but will have ongoing acute exacerbation of illness. And these are a group of individuals who continue to have very bad outcomes. So about 50% will actually go on to die within the first year of being in the ICU, though there are some individuals who live for many years as being chronically critically ill. And so what's interesting is in the United States, because this is actually a really quickly growing population, chronically critically ill individuals are cared for in what's called long-term acute care hospitals. And a while back, this was one of the fastest growing segments of the American healthcare system, is these LTAC facilities. In Canada, we don't necessarily have LTACs, but what we do have is a variety of residential care facilities that will develop specialized units that are capable of caring for individuals on a ventilator and with significant medical needs. And so back to my clinical colleagues, when we first started talking, we were talking about ICU survivors in general, but they had, this is a physician and a nurse practitioner, had started doing some ICU outreach to the community. And so they were going to see individuals who had chronic critical illness who were in one of these specialized units in a residential care facility. And they noted a number of challenges, and they really identified the need for research and asked me if I'd be willing to partner with them. And so to just get a sense of what some of the issues were, we had initial meetings. And one of the things we also did is we had a look at some of the data. And so the facility that we were looking at, the unit is a 22-bed unit. And so over the period of August 2014 to 2016, so it's 2 years, we noted that of the individuals in the 22 beds, there were a total of 105 unplanned visits to the acute care facility. Of those, 49 were emerge department visits, and 56 ended up were admissions to hospital. And these individuals, because they are still on a ventilator, they are not admitted to the average ward. They're admitted to either a high acuity unit or back into the ICU. And these 56 admissions accounted for 725 acute care days. So a staggering number of days at a cost of, we were ballparking it at about just over $2 million. So significant. We also had some conversation with management and staff, and the staff very much expressed difficulties caring for residents and what they were calling difficult families. So there was a lot of conflict with families, and staff were really struggling. So we decided to do some research. So this slide, I don't expect you to see the details of it, but what I wanted to point out with this slide is that what we were witnessing at this one small facility was actually not unique at all. And so this slide is based on an American study. And what they did is they followed 126 patients who entered a hospital. 99 were discharged to one of any number of these facilities. So these 99 patients basically were patients with chronic critical illness, and they either went to another hospital, an LTAC facility, a skilled nursing facility, which would be similar to what we have, inpatient rehab, or home. But what I want you to pay attention to here is all the lines between, so the red line and the black dashed lines, those actually represent all of the transitions that happened between these facilities. And the authors actually counted up the number of transitions between these facilities. And among the 99 patients who went to these facilities, over the course of 1 year, there were 457 transitions in care. So again, a staggering number of transitions of care between facilities. So it's not necessarily something that's unique to our context. This is something that happens to people with chronic critical illness elsewhere. Okay, so back to our research. We came up with two research questions. And the first was, what are the sources of distress related to disease prognosis and patient care? And we are interested in the perspectives of residents and family, as well as healthcare providers. But we are also interested in what the expectations related to disease prognosis and patient care actually were among these different individuals. And so I'm not going to go into too much detail about the methods, but this was a patient-oriented research and integrated KT approach. So we had 2 patient or family partners who were involved throughout this entire process with us as research team members. And the research also involved members from the facility in terms of managers and decision makers at the larger Fraser Health level. So it very much involved a lot of group meetings, which was really beneficial for the research. And so we managed to recruit 38 individuals from the unit. 6 of them were residents, 11 were family members, and then 21 were healthcare providers. I will note that the number of residents, though it seems rather low, we were quite happy with this number because it actually represented most of the individuals who were actually able to communicate despite their mechanical ventilation. Having said that, the interview data, these interviews often took a few hours, couple hours actually, and we had anticipated, because people were on the ventilator and can only sometimes get out a couple phrases at a time, that we would have to do 3 interviews over the course of 3 weeks. But once we got into doing the interviews, we as the interviewers actually had to bring the interviews to a close because people were just so happy to be able to talk about the challenges that they were experiencing. So though it was only 6 residents, the information power from those interviews was tremendous. And so all the interviews were in-depth and semi-structured interviews. And we used an interpretive descriptive approach to analyzing the data. We used coding, constant comparative techniques, lots of diagramming within the team. And so it very much also involved taking our results back to our team members and seeing if what we were finding in our interpretations were actually reflective of what they see and also clinically useful. So our intent for this study was to try to generate findings that could be used by decision makers at the facility. And so I'm going to quickly, just recognizing the time, I'll go through some of the results of the first study, or first paper. And this was really looking at distress and those sources of distress for residents. And, we were really surprised because of the, physical frailty of individuals. We were expecting that distress was very much going to be tied to physical symptoms. We were expecting, pain and breathlessness to be significant. But we were very surprised. Residents talked very little about physical symptoms. And instead, really for these individuals, distress was related to the tension between the really invasive medical care they required and this unmet need for a sense of home. And that was because they felt that care beyond their physical care was often overlooked. They were dependent on other people, but they often felt neglected. Many expressed frustration with limited choices and the ability to participate fully in making decisions about their day-to-day, but also about their health, and significant feelings of being sad and alone. So I will just go into a couple of these in a bit more detail. I won't go into all these themes. But residents were very much distressed when care beyond the physical was overlooked. And so part of this was that because they felt there was prioritization of highly technical medical care at the expense of these other symptoms or needs. And they felt that the basic or simple or little things actually were really very important because many felt they had lost everything else in their life. And they felt that when care beyond the physical was overlooked, they felt that they were not cared for, they felt they weren't seen, and they also felt that they weren't valued as people. And so one resident said, getting me up and getting me in a chair, yeah, they do that well. The grooming, not so much. They don't care if I look good or feel good. They just care that I'm up and dressed, basic. They don't take the time. They don't see who I am. I'm invisible. And so when we talk to healthcare providers, they actually recognize this as well. But they talked about how the residents, because of the fragility of their health, they described them as sort of living on a razor's edge. And they felt that they really had to prioritize medical care because they feared that if they didn't, mistakes would happen and they would die. And so, as I said before, distress was also because residents felt dependent on others but neglected. So they felt ignored, dismissed, and neglected. In part because sometimes the only interaction they had with a healthcare provider was in relation to medical assistance. And you can imagine many of these individuals, the only other contact they had with individuals was family who would come to visit. And so they felt that when they were neglected, it really undermined their self-worth, their dignity, and their sense of safety. As one resident said, no one comes in, does anything, and they're really comfortable basically just letting you be alone in your room for the rest of your life. And if I don't call my call bell, no one will come because they're always preoccupied. It feels like they just left you in a room to die. And so healthcare providers, they also recognized that they weren't necessarily meeting resident needs. And so they talked about feeling busy, run ragged, they were stretched to the limits, and very much struggled with, trying to trying to meet patient needs. Residents also talked about being cognizant that staff was really busy and that there were lots of needs among other residents. And so they didn't want to be a nuisance or a burden. And often they would limit their requests for assistance or anything that seemed to be above and beyond basic care. And so we were very much struck in the interviews and in this study by the deep sadness and depression and despair that was expressed by residents. There was also tremendous loneliness and social isolation, and lots of expressions of hopelessness and helplessness and worthlessness. And for many, they felt that their life had lost meaning. And part of that was that they did not feel that they were able to engage in really meaningful activities. As one resident said, I feel just generally like if I didn't have my family, I wouldn't even care to be alive. Like, I just don't even care. There'd be no point, in all honesty. It just feels like I'm just a little waste of a resource or just taking up space. And so family very much recognized the struggles of residents. And so they did their best to try to, be everything that they could to the resident, but they were also people who were juggling, looking after other family members and jobs and, everything else that people need to do. And so they also felt tremendously overwhelmed and exhausted. And staff recognized this. They recognized the emotional difficulties that residents were facing, and they felt wholly unprepared to provide the support that was needed. I'm just looking at the time. I'm going to skip over a couple of the slides, but what I will briefly say is that when we looked at the healthcare expectations of residents, though people recognized that they had a poor prognosis, there was a lot of uncertainty and a lot of ways in which they weren't actually making sense of the prognosis. And there was also a ton of conflict between residents and family and healthcare providers. And part of that was, healthcare providers saw that people were struggling, but they could not necessarily meet their expectations. And they also felt that family had unrealistic expectations that the residents were actually going to get better. And they felt that residents and family often lashed out in anger, especially when residents got worse. And the other important point is that residents didn't necessarily want to talk and focus on their poor prognosis. They were actually bringing attention to the importance of hope and how finding hope for even something small or maintaining hope, even when hope shifted, was really important to them continuing to live. Whereas healthcare providers often felt that that was false hope, and they got frustrated when residents and family didn't fully understand their prognosis, but instead chose to focus on hope. Healthcare providers also conveyed really the complexity of end-of-life decisions that happen in conjunction with these sort of unrealistic expectations and what they saw as overly high hopes of residents and family. Just briefly, some of the implications are that models of care that are holistic and attend to patient priorities are desperately needed. In a similar vein, psychosocial support is desperately needed. I will say that during the course of the study, because we were using an integrated KT approach, and management became very aware of some of what we were finding. And they had a sense of it already. They had started some recreational therapy, and it was very well received by residents. So the hope is that they will be able to continue focusing on creating and helping people emotionally and to create meaning. We also think that a palliative approach to care might be applicable, not surprisingly, and that is care that emphasizes the importance of a therapeutic relationship, that adapts knowledge and expertise to the actual individual, that ensures patient and family needs are addressed early and throughout the disease trajectory. So thinking upstream for these individuals, starting, when they're in the ICU, to think about what their needs might be. And then the last implication really is, I think we need to figure out ways to empower staff to engage in care conversations in a manner that does actually foster hope. And just very, very briefly, I just wanted to tell you about a study that we were supposed to launch last spring that looked at unplanned hospital readmissions following critical illness survival. But because COVID hit, we clearly had to put that on hold. And so we're hoping to get this up and going this spring. One thing that I wanted to point out that I think is rather unique about this study is that we're not just focusing on the patient themselves, we're actually focusing on the survivor and their family. And part of this is because of recognition of the importance of family caregivers to patients, but also that they are simultaneously suffering as well with what we call PICS family. And so we really saw an urgent need to identify these drivers of readmission, particularly social and relational drivers, but also gaps in the healthcare system. And so our aim is to, for this study, is to generate a robust explanatory model of the relationship between ICU survivors, their family caregivers, and the healthcare system, and really to identify those drivers of hospital readmission. So I'm really excited. This is going to be quite a large 4-year qualitative interpretive description study. And hopefully we can get started on this in the fall, or sorry, in the spring. Okay, so everything that I've sort of gone through today, I think points to the need for research to inform and be embedded in the development of health services. And there's a lot of work to be done. Okay, so I will stop there, and I thank you for your attention. I know this is somewhat unrelated to cancer, but I'm sure you can see many parallels, and I welcome comments or questions.